Anya Jastreboff, Darren McGuire, Mike Gibson here for This Week in Obesity. Darren, this week or last week at the AHA, a lot of discussion about the Summit trial. Talk to us about this agent in HFpEF.
Yeah, so this is another win in the field of heart failure with preserved ejection fraction among persons with overweight or obesity with or without diabetes. And so we've had the two previous trials proving semaglutide injectable has favorable effects on people with these conditions and heart failure related outcomes. The semaglutide trials, the STEP-HFpEF and HFpEF diabetes trials, both showed almost exactly the same thing. They were primarily designed for feel and function primary outcomes, so 6-minute walk distance, KCCQ questionnaire score for heart failure related symptoms, and proportional weight loss was a co-primary. And both of the trials were successful, almost identical findings. And so that set off a conversation about we have a new pillar, possibly, of therapies for HFpEF after going decades without anything new. We now have the SGLT2 inhibitors with an indication. We now have Entresto with an indication. Probably MRA and specifically finerenone will probably pull up the spironolactone data, I suspect. And now we have a fourth pillar for HFpEF, which is it's a nice parallel to the kidney domain. For 50 years, we had ACEs and ARBs, and now we have four pillars there too, largely overlapping with these HFpEF. But getting to the Summit trial that was just presented and published, another win for an incretin modulator and also for people with overweight and obesity who have heart failure with preserved ejection fraction. So tirzepatide, the dual GLP-1 receptor agonist, GIP agonist, versus placebo, showed statistically superior outcomes, including clinical outcomes, unlike the STEP-HF program, which was primarily patient-reported outcomes. This is actually all-cause mortality and heart failure decompensation that showed a statistically significant 38% reduction. So this is a big deal. And to buttress that, we see a lot of signals that very much mimic what we're seeing with semaglutide is that KCCQ improved, weight loss was achieved, 6-minute walk distance improved. So all of the features shown positive with semaglutide are reproduced here and also adding now the clinical outcomes. So this elevates the class, probably, certainly tirzepatide above all others.
It should be noted that there was a numeric increase, not statistically significant in mortality, just for complete disclosure. Anya, what do we know about the benefit or mechanism of benefit here? Do you just feel better when you lose weight and can walk more and exercise more? Or is there something fundamental going on here where the GLP-1 is really impacting the heart or the myocardium itself? What do we know about the mechanism?
Yeah, I mean, I think that that is a question that everyone is asking, and it started with, well, it was even before Select, but it really took hold with Select and the data there, and then has continued with this great interest in looking at what are the impacts of weight reduction itself and what are the effects of the drug. And people say direct and indirect. I think the effects of the drugs on weight reduction are direct. They're direct in the brain. And then there's peripheral effects that are direct in terms of inflammation or other things that we have to consider depending on the obesity related disease that we're looking at. And I think a lot of mechanistic studies will now be focusing on those things because these large trials have really brought this to light. Those trials were not designed to answer those types of questions. So I think we have to do our due diligence and figure out not only that these medications work, but how they work. And that'll also help us to determine who they work best for and who they can provide the most benefit for. I think one of the key questions that keeps on coming up over and over again is, do we treat patients once they've developed obesity related diseases? Whether it's HFpEF or diabetes or anything else. Or do we treat them before they have developed all of these diseases? And I think the answer is yes, meaning that we have to do both. But clearly, with millions and millions of people being affected, we really have to determine how they're working, who they work best for, and when is the best time to treat.
There's some interesting observations that I've seen, maybe they're preliminary, is that there's a lowering of BNP in these patients, which may indirectly speak about the direct effect. Any thoughts on that?
Yeah, I'll jump in here, and I was going to bring that up. It's and I think Anya will agree that with increasing adiposity for any given level of intracardiac pressures or transmyocardial tension, there's a lower BNP circulating, whether it's N-terminal proBNP or BNP. And it turns out that BNP, at least in part, is under testosterone regulation.
Hmm,
So when you lose weight, you androgenize,
hmm.
there's a paradox that even if your cardiac status is unchanged or even getting better, the BNP may go up, and that's associated with the weight loss and the sex hormone
But the fact
balances.
that it went
The fact,
down,
at least in the HFpEF program, it went down. That tells me at least some of the benefits are heart failure related. I think there's no other explanation. Now, certainly the weight loss helps, and certainly over time it helps more until people plateau. So they're going to feel better and function better just by losing weight. But I think heart failure is also getting better. Now, remember, when people take these medicines, they tend not to eat as much, and that means not eating as much sodium.
Yeah.
hmm,
So they're
I,
taking care of their heart failure by limiting sodium intake. And in Summit, there was a placebo-subtracted 5 millimeter mercury lower systolic blood pressure. And so afterload is reduced to the heart, so reducing myocardial energetics or improving energetics. So there's a lot of stuff going on that's above and beyond the weight loss, but certainly the weight loss helps.
yeah. I mean, and I couldn't agree more in terms of the change in terms of how people are eating and the impact on salt intake or, even carbs or anything else, but especially salt intake. And I think that even, looking at the select data, the focus was on, well, what's the weight loss doing? What are the other direct effects of the medicine? It was immediate. So to me, I'm like, well, what is immediately going on? And what's immediately going on is what people are actually doing. And that was obviously not something that was specifically looked at in that study. And I think it's incredibly important to look at that.
yeah, immediate, and in some trials looking at something as hard as mortality, some pretty early benefits. Again, is it multi-risk factor reduction? I mean, we have all these diseases, but it's a syndrome, right? And we are really treating all those risk factors at once, which is something different than what we do.
Yeah, I think at the heart of it all is obesity. I mean, if we were to treat that first, if
Correct.
we were, or if we were to treat that really early, or let's just dream and let's see, like, could we figure out how to prevent it? Not, and of course, we have to focus on the environment. Like, this does not, take away the absolute need to change our default environment, which is obesogenic and very unhealthy. But let's just say that, okay, we have this environment right now. Can we figure out ways to figure out who is at highest risk and prevent it? So right now we're at the stage of, if we can treat obesity, we can potentially prevent hundreds of other diseases. Not all, right? Not all those diseases. Some patients are still going to develop this regardless of whether they have a significant amount of adiposity or not. But if we can treat obesity, we can potentially prevent hundreds of other diseases. And what we haven't been doing is focusing on treating obesity. And so, yeah, and then I would say, let's dream and prevent obesity in the first place.
In
Thank
addition to getting all those risk factors down with treating obesity, we're getting down blood pressure,
you.
glucose, LDL, you name it. What we're also doing with this class of drugs, a lot of people stop smoking. So that's another risk factor that they're modifying. And, a lot of people stop drinking. I did a poll on Twitter, which is very scientifically based, by the way. And 80% of those people, it was like 3 or 4 to 1, people said, yes, when I started a GLP-1 agent, I cut down my alcohol intake. So it really has a lot of effects, like, again, making me question, where's the mechanism of action? Much of it may be centrally mediated through dopamine and dopamine reward circuits.
I mean, there are receptors all over the brain. And so in terms of the reward motivation pathways, that's likely where they're hitting. And if you think about it, when you think about food pathways and why we eat, why we want to eat as humans, right? Now we eat because it's time to eat, or socially this is the thing to do, or whatever. But we eat for pleasure, right? We eat because we enjoy eating. And that is one of the things that is really important, right? Because if we didn't have that desire to eat, and we didn't have craving and we didn't have hunger, we would die as a species. So those brain pathways were created for that. They weren't created for alcohol or smoking or other things, but those substances basically hijack those regions of the brain. So if we're hitting those regions of the brain when we're impacting food intake, then it's, to me, it's not surprising that we're also impacting those reward motivation regions of the brain in terms of these other substances. And the other thing to remember is all of these pathways work in concert. It's not like, oh, the hypothalamus, or oh, the prefrontal cortex, or the striatum. They all talk to each other. They all communicate, and one informs the other. I do think it's really interesting to think about how these medicines impact whether it's food intake or alcohol intake or anything else during different phases of weight reduction. So I think it's important to counsel our patients on the fact that as they are losing weight, as they are chasing a new defended fat mass or a new set point, their appetite and their craving and their hunger is going to be markedly reduced. But once they plateau, the craving and the hunger will come back, but the weight won't, as long as they're taking the medicine. And that is really, really important, because if we don't share that with our patients at the get-go, they think the medicine stops working, and it doesn't stop working. It's just that your body is no longer chasing a new defended fat mass or a new set point. And that's why hunger and craving comes back, because now it's like, okay, I'm good. And some days people eat more and some days people eat less. But the point is that they're not gaining back the weight as long as they're taking the medicine. At least that's what we see in clinic for most patients.
Fascinating. Well, thanks you too. Thanks for joining us here, and thanks to all of you for joining us here for This Week in Obesity.